Hello and welcome to Home Health Recharge here on the Senior Rehab Project. Today we continue with the panel discussion that we started last time. But before we get to that, I want to tell you that this episode is sponsored by the Academy of Geriatric Physical Therapy. The AGPT works hard to provide us Geri PTs with high quality content to help us advance our practice. This year's combined section meeting is a great example of that. The AGPT is offering 3 pre-con courses in DC before CMS starts. This year, you can learn the fundamentals of Tai Chi, how to apply a comprehensive approach to successful aging, or how to effectively manage kyphosis. So without further ado, let's get back to the panel discussion.
So we're finally getting some questions in on Facebook Live. Y'all ready for your first Facebook Live question?
Shoot.
So it's from Philip. And he says, I am trying to learn more about the CY 2009 Medicare home health payment rule. How do you expect this to change the way PTs treat and document? How will this change the number of visits and recertifications for patients? Who wants to tackle that one first?
I think it's Jamie.
Wow. I mean if we're going to talk about something that takes up all of our Facebook time,
Right.
this might be it. Because I think,
Inside.
I think part of this answer has to look back at what therapy's been doing in terms of where we think it's going to go. And at least within the Part A component of things. I know, again, Part B got a different, I won't call it boom with the budget changes versus what Part A, as far as physical therapy and home health, has to manage in terms of the Part B cap being waived, whereas we essentially got taken away the idea that the number of therapy visits counts in terms of reimbursement and payment. So, but that's always been the part of home health that's driven therapy from a business model, is that when you add therapy onto the case, the company essentially makes more money off of it. So the outcomes were kind of a side. We like to talk about the OASIS outcomes and how it makes us look on a public view with Home Health Compare and how we stack up against other agencies. But until now, it's always been discussed as a potential indicator of how we make out financially, but it was never really driven home. And now the outcomes are going to be more important. So the number of therapy visits it takes to get an outcome, I don't know that we know the answer to that. We're still figuring that out. You know, the article that was published recently by Jason Falvey talking about total knee replacement and the number of therapy visits needed to get positive functional outcomes. This is something that we've been working on for as long as I've been in home health, and that's now 18 plus years, and we still don't have a good answer. We have an idea of how many, and it's kind of like play that with that game, name that tune. You know, I can get this personal functional in 5 visits. I can do it in 4 visits or 7 visits. I don't think we have a good way of predicting it. I think if we, as a discipline in terms of physical therapy, and I don't want to be exclusive, because I think therapy in general with occupational and speech therapy, we've been kind of just shuffled around as little pieces to make the model work for the agencies that are attempting to stay alive financially. But for our own profession, I think we need to develop better standards so that we have an idea that when we walk into a home and we start talking about goals and discharge planning, that we have a better idea of where we're going to take our patient. And if we can do that in 6 visits, I think that's awesome. But I think some people are going to need a lot more. And we need to be able to document and state why they need that. Why I, as a PT or an OT or an ST, need 10 visits or 12 visits to get to my outcomes and have a nice patient experience, but also be mindful that this does cost money. Insurance is paying for this. And in the case of Medicare, that's tax dollars. And how do I be a good steward of that money? Look, we could talk all day on this one. I don't think we have enough time for, because I think I opened up a few more rabbit pathways on that one.
I think that was a good, concise answer, though. I think you were hit the nail on the head. So let's go to the next one. Let's start one that came in from Ken Miller. What do you consider homebound and home health? Since Celeste doesn't want to start with her, we'll start with Nick. Nick, you want to start this one off?
Sure. Yeah. Well, I think it's supposed to be a considerable and taxing effort. I guess I just try to see, like, can this person like reasonably get out of the house and, get to outpatient, and, are they getting short of breath? Is there, sometimes in the rural setting, maybe I try to kind of be a little bit more lenient on, what the exactly taxing effort is, because of kind of the transportation issues, even though that's probably not supposed to be exactly taken into consideration. But just trying to do what is best for the patient, as far as getting services, and kind of looking at it holistically. That's kind of my answer.
So there's specific criteria for homebound status in the Chapter 7, which means that, they have to have somebody, they need help of a device or a human to get out because of an illness, or it's contraindicated. And then if that is the case, then there has to be that normal inability to leave the house. So that's where your taxing effort comes out. And they specify, if you look at the Chapter 7, they're pretty good at giving examples of what is and isn't homebound. And, a lot of times I'll hear some of they'll have someone on homebound status because they have a wound, or because they can't drive, which doesn't necessarily make somebody homebound. I mean, there still has to be that inability to get out of the house, that it takes a lot of effort. Say you can only walk 50 feet and you have to go to the doctor's office and you have to get all the way in. So those are the things that I look at, not just if they can or can't drive, because there's nothing that says, they can't drive. I've done a lot of rural home health, and they're, somebody living alone out in 50 miles from a grocery store needs to get groceries. So you get in your car and go, you do what you have to do if there's nobody there. But that's going to be a taxing effort. It's going to take a lot out of them. So that you kind of have to look at the entire picture. Next.
Yeah, and this will be a brief plug too, because if anyone's going to be at the Combined Sections meeting in Washington, D.C., one of the practice committee work groups that I was part of was medical necessity, defining medical necessity, and a part of that was also defining the homebound criteria. And there's two components to it. Part of that is the taxing effort. Another part of it is, when they are leaving, what are they leaving for? Is it a medical appointment? If they've got dialysis 3 days a week, that's okay. If they go to the senior center or an adult daycare, there are some aspects to leaving the home that is okay and is allowable. Going to church once a week, going to get their hair done once a week, those kind of things are okay, even though they're not medical related, but they're infrequent and they require some level of assistance to do it. So I've been in those conversations with our care conference team meetings where someone says, well, so-and-so's driving, so I guess we have to discharge. And I go, well, wait a second. Well, where were they driving to? Well, they had to go to the pharmacy to get their medications. I go, well, do they have anyone else to do that for them? No. I said, well, then maybe they're still homebound, but they had to make that trip because A, they need their medications, and B, they're only doing it one time. And then they're not planning on going out to go meet so-and-so for lunch and then go to the movies and then go on a trip to an amusement park or whatever it is. So you do have to take that in consideration. At the same time, they may be homebound, but they may not have a skilled need for us to be out there. And so I think it's important that we, in order for us to be in the home to provide home health services under Part A, we do need to understand what the criteria is, and homebound status is one of those, but it's not the only thing.
I think that was very well said from everybody. And one of the examples that I always like to give, and given our current political climate, it's really applicable, was I had a client once that was told by the nurse that she would no longer be considered homebound if she went out and voted. And that obviously is not a reason for somebody to not be considered homebound, particularly when the political affiliations between the nurse and the client were on two different spectrums. So I did try to very clearly explain to my client that she would not be discharged from therapy, which is really what she was most concerned about, if she were to go out and vote. But it's for me, I think it's especially, this is a really challenging thing for me as a clinician to kind of understand, because I work on both sides, A and B, and I often refer my clients under B to Medicare Part A. And when I see that happening, it's really a matter of like understanding that what we're doing, this client is now homebound, and they would require that Part A service. And so by me continuing under the Part B model, I'm not necessarily providing that client with what they truly need. So I think it's really that strength across the spectrum of our profession, that really looking at what is available for the client and what they really qualify for.
Heather, can you, this may be more of a question for you, can you expound on the differences between working with someone with Med A and Med B in the home?
So the only true definition between Medicare Part A and Medicare Part B in the home, as I come to understand it, is that the true homebound status. If a client is truly homebound, then they should be seen under the Medicare Part A model. But a lot of my clients are not homebound. A lot of my clients are very high level functioning. Under the Medicare Part B model, it just might take them longer to get to a clinic. And so maybe they don't drive. And like Celeste said, not being able to drive does not mean that you're homebound, right? And so if they could get a family member to come and take them to an outpatient clinic, then that's really the model in which they should be seen under. So in the Part B model, I'm actually just taking it directly to the client and providing those outpatient services in the home. And my goals are higher level functioning, more community mobility based, versus my Part A goals are more concerned with like safety in the home, and being able to get them ready to access the outpatient therapy.
I have a question for Heather.
Okay.
on the Part A and Part B, because you have that ability to be in both with those services. And I think the question would be, when someone needs other disciplines, like a social worker, like a skilled nursing visit, would that then qualify them to be Part A, even on the, if you're thinking therapy wise, they might do okay at an outpatient clinic, but they still need these other services? Would you then hold off on recommending the outpatient until they've completed? Because I don't know that Part B covers like a nurse coming to their home under Part B, or would it for you guys?
So it really all depends. When I have a client in the community that has more complex, like a more complex case, I will call the physician and have the conversation with them first and foremost, and I'll go based on their recommendations. There are Part B services that are provided in the home for, such as wound care. So I can actually, continue to see a client and they're seen under Part B through a nurse practitioner for wound care in their home. So there have been cases where I've been referred a client and they still have Part A needs. And so I will hold off until they've been seen fully under that Medicare Part A model.
All right, good question. So we'll move on to another question that we got. If you only had 4 items to take with you into the home, what would they be? Who wants to start with this one?
I'll go. Why not?
Okay.
I would take my stethoscope.
There we go.
And my blood pressure cuff. Those would be my top 2. And I would have my phone as my third, because I can use it as a timer to take heart rates. And I can use it for music, so entertainment during the session. And then I would have my work device for doing point of service documentation, so I don't have to take that all home with me. Those are my 4.
So this doesn't count our bag? I was thinking of it as in I have a bag and I get 4 extra things. I want my extras.
No, this is the desert island question. You only can pick 4 items.
Just 4.
How do you survive?
Okay, the phone definitely, because there's the Clock Yourself app and the Gate Speed and all of those wonderful apps on there. And you can do your point of service documentation. It's a little small, but you can at least get some stuff done in there. There's one. I like the duct tape or tape of some sort. I might have to come back. Can I wear the weight vest in as my clothing?
I think that's illegal now. Can't do that.
That's a bold fashion statement.
Yes. Yeah.
I'd say the only thing I would change out from what Heather was saying is I would change out the point of care device for hand sanitizer, just because I don't get dinged by Joint Commissions.
Good choice. On that desert island where they come.
Well, they would find us. It doesn't matter what desert island you're going to be on. Hey, look, surveyors are here.
The Big Brother.
Yeah, that's right. Nick, do you have anything to add? What would you like to take?
I didn't think of my phone, but yeah, I think I definitely want that. I was going to say a pulse ox and way to measure blood pressure, and then my phone, and maybe a goniometer. I like to, especially if it's a orthopedic patient or if they're a fall risk, I always like to take dorsiflexion range of motion, and sometimes hip flexor, hip extension range of motion too. So.
Hey, if you've got your phone, there's an app for that.
Oh, well, yeah, that's true.
You get one more.
Wes using her phone for everything.
Maybe like an AirX pad for balance stuff.
Those are all good choices. All good choices.
Yeah,
So
realize the phone, you can call Uber. You don't even have to take your own car.
Thank you for listening to the Senior Rehab Project. If you gained from this episode, consider supporting our work. You can become a patron through Patreon, a service that allows people like you to support people like us. You can give as little as $1 a month or become a game changer for $8.99 a month, where you get this awesome redefined old mug and access to our monthly meetups. They're really a blast. Just go to theseniorrehabproject.com to learn more and find the show notes for this episode. Talk to you soon, and don't forget to stay funky.